So, what is AI? There might be around 10,000 plus AI companies already in the healthcare space. By quick show of hands, please raise your hands if you have already heard of these company names like Cure.ai, River Rain, Optilum, and so on. The list goes on. What do these companies all have in common? They are all artificial intelligence companies who build products or services to the healthcare industry. As you see in the Venn diagram on the left, AI is a broad field that includes technologies and techniques for intelligent thinking. A subset of this AI is called machine learning. It is like a computer program that can help machines to learn new things by themselves without being explicitly programmed. Imagine you're teaching a baby on showing them pictures of a car and saying this is a car. You start with one picture and eventually you show them a few more other pictures. Eventually the baby, when you show them a new picture of a car, it identifies that it is a car. That's exactly what we do with machine learning. A subset of machine learning is deep learning, which uses complex mathematical models called neural networks to mimic the way human thinks, which makes all of this possible. The major constraints for developing these complex algorithms are twofold. One, AI requires large data sets of high quality to get trained and to be tested. Machine learning models are only as good as the data. So if there's any biased data, so will the output. Moving on, now that we understood what AI does overall, we will quickly cover about the challenges in the early detection of lung cancer. So lung cancer is one of the most prevalent and fatal forms of cancer, with 2.1 million cases annually reported and 1.8 million deaths. A major issue with lung cancer is that more than 50% of the patients are diagnosed in the later stages, and also most of these patients are asymptomatic. So the challenge lies in identifying and detecting patients as early as possible. What are the possible solutions? The most prevalent solutions that come to mind for early detection of lung cancer are two. One, the lung cancer screening programs, or identifying and managing incidental nodules that are detected on other modalities. The post-NLST and Nielsen trials, lung cancer screening program has become an evident solution to find lung cancer early. In fact, in the bar graph, stage 1 cancers identified outside versus via screening program, you can see a steep surge from 16% to 17%. This is based on an article posted based on US lung cancer screening program. Along with the cost effectiveness, lung cancer screening program has other challenges like huge volumes of chest CTs, follow-up CTs, complexity of the follow-up CTs being 3 months, 6 months, 12 months to identify malignant patients. Also false positives and overdiagnosis coming with it. So these are some problems to address for lung cancer screening program. Incidental lung nodule detection. One untapped funnel for identifying malignant patients is to analyze millions of chest CTs and X-rays taken from non-oncology departments. These are patients coming, inpatient, outpatient, who are coming for various other symptoms. So these patients, when they undergo these CTs and X-rays, and you can detect lung nodules on those patients, you are potentially increasing the funnel of finding early lung cancer patients. In fact, there was a study done by Cure.ai in Philippines where roughly 33,000 scans were processed retrospectively and 6% were found out to have nodules in those X-rays. Further, assuming a 10% would actually have malignant nodules, that's roughly about 200 early stage lung cancer patients who were not taken forward. How can AI help? And here's where Cure solutions come in handy. So this is our QCT Lung, which is our chest AI model to detect and analyze lung nodules ranging from 3 mm to 30 mm in diameter. So far, QCT has been trained with more than 200,000 data sets DICOMs across hardware, across geographies, and other DICOM related parameters. Further, with pulmonologists, we provide an adaptable version wherein the results produced by QCT can be corrected in cases of overcalling or undercalling. With internal data, we have achieved 95% sensitivity and less than 1 false positive per scan. When I say we analyze QCT nodules, what does that mean? We do characteristics like calcification, speculation, texture, which is solid, subsolid, diameter, volume, etc. These are generated, and together, if there is digitally available clinical information, we can automate generating lung RAD score, Mayo score, or Broke score relevant to the hospital or the site. Nodules, which can be compared from baseline to follow-up CTs. We can match the nodules across these CTs and show progression or the aggression of the nodule, which comes in handy to understand how the nodule has progressed over time in this graphical visualization. Reporting can also be done, and this can be configured as per the templates and the hospital site requirements, and can be preset. There was an MRMC study done for this model QCT, which was done with radiologists. This paper got accepted as an abstract at ECR, wherein we showed a 46% reduction in time on spending time on the scans, a reduction of 76% false negatives, overall 6.6% increase in sensitivity, and 33% increased inter-radiologist agreement. This has happened very recently in December. We've completed CE MDR clearance for the QCT model, where we've worked with our Center of Excellence partner Erasmus University in Netherlands. We've processed around 300 CTs for performance evaluation of QCT. Overall sensitivity is 89%, specificity is 84%, and AUC of 0.87. On the table here, you can also see for the characteristics how QCT has performed overall with their sensitivity levels. So this paper, along with the publication, we are now CE Class 2 MDR certified for the QCT product. Here's an interesting challenge. So QXR is AI for chest X-ray model to detect nodules and other 29 abnormalities on the chest X-rays. Further, for detected lung nodules, QXR is able to analyze these nodules as per the segmentation model to generate a malignancy risk based on the nodule characteristics like calcification, speculation, solitary nodules, and texture. QXR is in fact Cure's legacy product with 1,000+ deployments in 60+ countries. We have trained the model with 4.2 million data sets, and annually we process about 3.7 million scans already. Across many geographies and sites, we've done a lot of performance validation for QXR. That's how you know that the model is unbiased and is ready for the market. So here's 3 interesting studies which show how the QXR has performed and showed significant sensitivity and specificity levels. So that's it from my side. 2 things I would like to add. Our partnership with AstraZeneca, which has been ongoing for 2 years, we have implemented in over 20 countries. The objective of this partnership is to use chest X-rays for the incidental detection pathway, and we're able to do that. And at World Economic Forum, together we've announced processing of 5 million scans before the end of 2025. The agenda is to see if chest X-rays can be used for incidental nodule pathway. And one other thing, we are recipients of SBRI award, which is in collaboration with NHS experts and thought leaders like Dr. David Baldwin. And here we're trying to analyze and reduce the time to report chest medical imaging, and thereby decrease the delays in identifying lung cancer patients. Here's an interesting QR code, if you will. You can scan it and see the latest offerings by Cure.ai. A slide and the experience.cure.ai is something that my colleague Ritvik and Vikas have put together for you guys to see the products firsthand and experience how the outputs of our models look like. Thank you, and thanks for the opportunity.